Welcome to the first series of the Clinical Toxinology webinar organized by the Emergency Medicine Department of Hospital Chancellor Tuanku Muhriz in collaboration with the College of Emergency Physicians, Special Interest Group in Clinical Toxinology, Remote Envenomation Consultancy Services, and Malaysian Society on Toxinology. In this webinar and forum, we aim to explore the topic of clinical toxicology. Is it relevant to medical students?
To deliver our welcoming remark, please join me in welcoming Associate Prof. Dr. Ahmad Khaldun Ismail. He is a consultant emergency physician, the founding consultant or advisor of Remote Envenomation Consultancy Services, and founding director or advisor of the Asian Marine Animals and Snake Envenoming Management Symposium. He is a member of WHO Global Roster of Expert and Technical Advisory Groups on the prevention and control of snakebite envenoming. He is currently an honorary scholar at Graduate School of Medicine, Tohoku University, Sendai, Japan. Honorary consultant at the National Poison Center, University Science Malaysia, and a resource person at the Malaysian Biodiversity Information System, Ministry of Energy and Natural Resources. He was the president of the Malaysian Society on Toxinology and a review advisor for the WHO Snakebite Envenoming Working Groups. His special interests are in clinical toxinology, emergency medicine, and pre-hospital care. He founded various educational programs related to the clinical toxinology for the public and healthcare professionals. He is passionate about teaching and frequently invited as a speaker in Malaysia and internationally. He holds the authorships of several academic publications in related areas of interest. He enjoys traveling, nature, swimming, and good coffee or tea. Without further ado, Prof, the mic is yours.
Thank you, Gan. Thank you, the moderators. Welcome, everyone. This is our first webinar on clinical toxicology. Is it relevant for medical students? This is our third year running the program. And we found that this is a very good platform for especially students to ask questions and generate discussions regarding clinical toxicology. I would like to say thank you to our esteemed panelists for this series, Dr. Hassan, Dr. Patrick, and Dr. Sabrina. All are great colleagues of mine and doing great job in clinical toxicology wherever they are. And we hope that you, the participants, will get some insightful points from each panelist when we discuss cases towards the end, in the middle of this presentation. So without further delay, I would like to say also all the best to our moderators and also our committee members who've been working very hard these past 3 weeks to make this program a success. So with that, I would like to wish all the best, and I'll pass back the mic to our moderators. Thank you.
Thank you, Prof.
Ladies and gentlemen, joining us today, we are very grateful to have the panel of experts. First up, we have Dr. Ruth Sabrina. She is an emergency physician with special interest in clinical toxicology and toxinology. She completed her subspecialty training under the Malaysian Ministry of Health program in clinical toxicology in 2019. She has been an emergency physician since December 2013 and a clinical toxicologist since April 2019. She works in the Emergency and Trauma Department, Raja Permaisuri Bainun Hospital, Ipoh, Perak, Malaysia. She is currently the President of Malaysian Society on Toxinology for the 2023 and 2025 session.
Next up, please join me in welcoming Dr. Hassan Adam. He has been an emergency medicine specialist in Repulse Hospital, Brunei, since 2013. He was an emergency resident at Emergency Department of University Malaya. He graduated from Al Ghazira University, Sudan, then proceeded to complete his master in emergency medicine in University Malaya, Malaysia. He also completed fellowship PhD MTox in 2018 in India. He has a special interest in all aspects of toxinology.
Finally, please join me in welcoming Dr. Patrick Tiglau. He is an emergency medicine consultant at the Department of Emergency Medicine, University of the Philippines, Philippine General Hospital. He graduated Doctor of Medicine from Pamantasan ng Nutsat ng Manila and did his emergency medicine residency training in University of the Philippines, Philippine General Hospital. He is currently the president of Philippine Toxinology Society and fellow of Philippine College of Emergency Medicine. A warm welcome, doctors. Thank you for joining us today.
Thank you so
Next
much.
up, welcome, doctors. Next up, we'll provide a brief introduction to our fellow final year undergraduate medical students on the topic of clinical toxinology. What is toxinology and what is clinical toxinology? Toxinology is the scientific study of substance produced by living organisms, either delivered as venom or residing within tissue of animals, plants, mushrooms, and bacteria, which may harm target organisms. While clinical toxinology encompasses a broad range of medical conditions resulting from either envenomation by venomous terrestrial and marine organism or poisoning from ingestion of animal or plant toxin. We have to remember that toxinology doesn't equal to toxicology. As I mentioned earlier, toxinology is the study of the toxin, poisons, and venoms from the plants, animals, and microbes, while toxicology is the study of the effects of toxin as well as other chemical substances on living organisms. Next, I would like to share a bit the difference between envenomation and poisoning. Envenomation is the exposure to venom containing toxin resulting from bites or sting from venomous animals, while poisoning is the administration of a poison inside one's body either via swallowing, inhalation, or absorption through skin. To remember it easier, you can just remember this sentence: if you bite it and you die, it's called poisonous, while if it bites you and you die, it's called venomous. There are various organizations in Malaysia that work regarding toxinology in Malaysia. We have MST, which is the Malaysian Society on Toxinology, established in 1992, the sole body in Malaysia to dedicate its purpose on toxin research and clinical toxinology. Since its formation, MST has been a significant number of high-quality research and publications contributing to the field of toxinology and medicine. Next, we have REX, which is the Remote Envenomation Consultancy Services. It is a risk management support system developed to assist healthcare professionals at various levels of clinical management for envenoming and poisoning. The main objective is to enhance a favorable outcome by optimizing and advocating appropriate treatment modalities at every level of clinical management. We also have clinical toxicology, special interest group, CEP, which is established recently in 2022. MyBIS, which is Malaysian Biodiversity Information System, aim to collect information related to Malaysia's biodiversity from a variety of sources and to create public awareness on biodiversity and environmental issue. And lastly, we have National Poison Center, NPC, which is a consultation center for drug and poison information and poisoning management. It was established in 1994 and is based in University Science Malaysia. Why does it important of clinical toxinology for medical students? Mainly because the cases are common in Malaysia. It is an emergency care and most of them are life-threatening. Next up, we'll have 5 case presentations. After each case, we will invite the panelists for some discussion and followed by a short Q&A session. The audience can drop their queries in the chat box during each case presentation. Now let's start with our first case.
Okay, now we will kickstart to our case 1, which is rotenone poisoning from ingesting Daris trifoliata laur. So a 7-year-old girl weighing 20 kg presented to a clinic after ingesting one Daris trifoliata seed. She complained of dizziness and vomiting soon after ingesting the seed and found unconscious 30 minutes later at home by her parents. She was transferred by ambulance to emergency department. So on arrival, the GCS is 3 out of 15, pupils is 3 mm equal reactive, heart rate is 87 beats per minute, BP was 90 over 55, respiratory rate is 30. The SpO2 is 100% on face mask oxygens. There's a presence of closed mouth breathing and poor peripheral perfusions. Examination on chest at abdomen is unremarkable. The ECG showed sinus rhythm. So the action taken at that time, so the patient was given IV normal saline bolus and the clinical state improved. During that time, the GCS improved to 10 out of 15. The heart rate became 102 beats per minute, BP 112/81, and the respiratory rate became 21. SpO2 was 100% on nasoprong. Hence, the patient was admitted to pediatric ICU later. So there's some investigations done during that time. So the ABG showed a severe metabolic acidosis with the pH of 6.9. The partial oxygen pressure was 262, and the partial pressure of carbon dioxide is 14. The bicarbonate ion is 3.1, and the base excess is negative 27.5, and the serum lactate is 12. Otherwise, there are other blood investigation done, which are urea, normal, sodium is normal, however, the potassium is low. Creatinine is normal as well. Liver enzyme was normal, and salicylate levels were undetectable. There's a contrast enhanced CT, brain CT was done, and it was normal as well. Next, the patient was intubated and ventilated as she remained drowsy and restless. IV sodium bicarbonate infusions is given to correct the metabolic acidosis, as well as IV potassium chloride to correct the hypokalemia. She developed persistent hypotension despite fluid resuscitation. Hence, she was started on IV noradrenaline infusions at 0.05 mcg per kg per minute and titrated to a maximum dose of 0.075 mcg per kg per minute within 7 hours. And the sedation was maintained with IV midazolam 2 mcg kg per minute and IV morphine infusion 40 mcg kg per hour. So over 36 hours, she showed progressive signs of recovery of the metabolic acidosis, acute kidney injury, and normalization of the serum lactate. On the third day of admissions, the child was successfully extubated. All serial blood parameters remain within normal ranges. She was discharged after 5 days with outpatient clinic follow-up. So now I would like to invite the panelists to give their comments about the case which I presented earlier. Thanks.
Can I proceed?
Yes, Dr. Hassan, go ahead.
Okay. First of all, thank you very much for having me into this useful forum. And I think Dr. Khaldun and his gang's doing the best possible for all of us, not only us, but also our patients. So thank you for that. And thank you for the organizing committee. So let me go into your case. Before I proceed with the case, probably I might just want to give a bit of a context about my background, because that it might helps me much understood when I talk about this particular case. I'm from Sudan, far north of Africa. So for those who might know a bit of geography, or maybe still remember it, that is like hot, dry climate. So that means whatever green is seasonal, and whatever in the water, it might not be there. So mostly desert. So back to the story. When you mentioned that this young child has consumed some Doris or dairies, honestly speaking, I have no idea what you are talking about. And even after I have seen the picture of the consumed plant, yet I'm still kind of not sure what is that. But as a clinician, as a medical student, still we should have the ability to deal with these kind of cases. So the question will be how? The best approach to these kind of presentations, regardless whether we know the kind of causing agents or whatever agent that might lead to these kind of symptoms, we do know some sort of kind of like wide-based knowledge to enable us to kind of syndromically approach those kind of cases. And once I say that syndromic approach, that means we are not sure, but we try to kind of zooming in the whole symptoms presentations, and we make sense out of it. So based on this kind of approach, and though I don't know what is that there is, I could say these plants, it might have some sort of neurotoxic effects. Why I'm saying that? Simply based on the presentation, based on the initial symptoms, and based on the progression of the clinical scenario later on. So obviously this young girl, she has shown some sort of initially vitals wise looks to be okay, but if you look into the some elements of investigations, there's a bit of warning signs. What I mean by that, if you look into the pH, it's like kind of acidated. If you look into the lactate is kind of high. So the combination of high lactate and deep acidosis, that kind of rings bells. Is it because of perfusion issue or because of, it could be just respiration issue? So based on these two possibilities, we can tailor our, let's say, some sort of supportive care at the moment, because up to now we don't know what is the that there is, at least for me. So whatever kind of interventions that was started, I think it is spot on, because by the end of the day, the supportive care is the most important elements of that what's so-called syndromic approach, because you just need to buy some time for your patient to fight, and at the same time also you need to buy some time for yourself as a clinician to find out. Maybe you just need to uh, pull out your phone and call Dr. Khaldun, and maybe a few minutes later everything will be solved. But unfortunately, not everyone is privileged to have access to these kind of platforms in a different part of the world. Anyway, my intake for this particular case is we will go syndromic, and we start with the supportive care, and then we will see how we can find out and whom we can call to get us some sort of like spot on infos, and then we might get into a definitive diagnosis. Yes, I can see that this from the first slide that is like retinol. I'm not so familiar with that kind of poisoning material, and I don't know even how the pathophysiology of it. But as I have said, still I have my two golden rules or golden approach: syndromic and supportive care. And that's my intake about this.
Okay, thank you, Dr. Hassan. What about Dr. Patrick? Have you had any issues with this type of poisoning in the Philippines?
Yeah, first of all, well, I would like to thank the organizers for inviting me to be a panelist on this um, webinar. No, so uh, uh, I haven't seen or haven't experienced any kind of uh, poisoning such as this, but as mentioned by one of our panelists, as an emergency physician, the first thing that I will do for these cases is to just systematically manage this patient, the airway, breathing, circulation, disability, and exposure. So for this patient, I think the patient was eventually intubated um, during the course of the management. No? So I think I have somewhat I have typical plant poisonings, and these plant poisonings would have neurologic effects as well and gastrointestinal effects. For this one, I think it's more of neurologic effects, and it manifested with a possible airway compromise of this patient. So as an clinician, as an emergency physician, I would stabilize the airway, intubate this patient, and then um, do some additional laboratories to know uh, the possible derangements in specifically some of the electrolytes or even the acidosis that the patient had, and supportively manage this so that the patient will be well while ongoing management. Uh, the airway breathing circulation is typically the essence of managing these patients, even in toxicology and in toxinology. And as a clinician, as a clerk, intern, or a resident, I think um, these are the basic principles that we should know, even though that we don't know what type of uh, chemical or toxin that the patient ingested. So, but for this one, I haven't really experienced this uh, trifoliate, but maybe some types of leaf or fruit ingestion that's similar to it.
Yeah, Dr. Sap, any comment about this case? This is actually our first case of such a there is trifoliata, which is actually not a new plant or that we see in Malaysia. This is actually commonly used in the past as a traditional way to fish. Means they take parts of the tree, beat it up, take the sap, and put into the water, and all the fish in the area will float, and they can easily collect the fish. So it's a fishing by poisoning lah, in a way. So, but this case is a accidental poisoning where the child thought that I mean they collect the fruits of this plant and thought it was edible. So this child apparently swallowed the whole seed, but the other friend bite and doesn't taste good and spat it out. So the friend was okay, but this child developed all these signs and symptoms quite early on, within 30 minutes after eating, you know. So yeah, what do you think about this kind of plant poisoning in Malaysia? Any comment?
In Malaysia, we call it as tuber ikan because
Tuba, yeah, tuba.
so basically, yeah, this is I think for me, it is a first confirm of rotenone poisoning that we have. Thanks to the experts that actually identify the plant. But I agree with the two panelists before, Dr. Hassan and also Dr. Patrick, whereby if we do not know the substance that the patient ingests, syndromic approach and stabilization of the patient's airway, breathing, and circulation is very important. Um, as we know that if there's any instability in airway, breathing, or circulation, we do not stabilize the airway, or the breathing is inadequate, or the patient is appears hypotension. If we do not stabilize, patient will also collapse. So in this kind of case, I think the managing team has already did successfully by actually managing the patient's stabilizing the patient's airway, breathing, and circulation. And after while stabilizing the patients, they actually seek for help from Prof. Khaldun and from the National Poison Center to actually try to identify the source. Of course, at that particular point, when the patient, when it is been identified, patient might already been admitted to PITS ICU and further stabilized. But if we can see from the clinical examination, from the physical examinations, yeah, it's some sorts of actually a neurotoxicity plan. Maybe the toxins is like that. But the most prominent features that the presenter presented is the abnormality in the ABG or VBG just now, whereby the acidosis is much of the lactic acidosis. So in plant poisoning, if we learn further, there are about 8 or 9 toxins that we can classify together, namely the convulsant, the sodium channel blockers, the mitochondrial toxins. So if let's say we know that the patient is having a lactic acidosis, probably the plants is some sorts of have the effect on our mitochondria that can cause accumulation of the that cause a block of the function of the mitochondria, causing lactic acidosis probably. Until then, I think the syndromic approach actually is the way to go. And in this patient, the sodium bicarb is actually being given, to treat and to buy time. And in Hong Kong, when I opened up the Atlas of Poisonous Plant, they have actually description about the poisonous parts of the rotenone. And they state that the rotenone actually inhibits the mitochondria type 1 that can cause the lactic acidosis. And that's all from me. Thank you.
Thank you, Dr. Sabrina. Just want to also understood the situation of this child. This apparently poisoning is very rare. Most of the time that we saw in the previous report not accidental. It's mainly for suicidal, right, or self-harm. And children are more susceptible, or adults the same with adults? Do you have any input about that? Because the child, maybe the body weight is less than adult, maybe the effect is maybe more severe in the same amount.
I haven't encountered any case of adult that actually have the confirmed rotenone poisoning, but in children, being their behavior of wanted to explore, and for the younger children, they like to picking up or whatever things that they saw. So probably they can just pick the fruits of the plants and just ingest it. In this case, it's about 7 years old, is it? So still in the period of exploring. When they saw something, they want to just bite it. So I think the nature of the pediatric patients as well. In terms of whether the pediatric with a BSA causing more severe signs and symptoms, I didn't encounter such statement as yet, but probably yes, but need to look more on the literature review. Thanks.
Okay, Dr. Pat and Dr. Hassan, anything to add about this case?
I think I
There
might
is
not.
no antidote, right? There is no antidote, right, for this poisoning?
I might not have anything to add, but I'm just get a bit curious. You did mention, Dr. Khaldun, that those kind of plant used to be used for fishing.
Yes.
And my question would be, where that fish will go?
No, they will take.
I mean that they use this kind of toxic plants to catch the fish.
Yeah.
So
the
would that
fish.
fish will be also poisonous?
Yeah. No, the thing is that the fish will be sort of like it's like they are high or something, I think. They're not completely dead, and it doesn't affect those who eat the fish.
Oh, just kind of incapacitation of the fish
Yes,
itself.
yeah, it will kind of
Okay,
start,
right.
floating up on the surface, and they can just easily pick it up, put into the basket.
Oh, interesting. All right, thank
Yeah.
you for that.
Okay. Yeah, maybe it's
Tabu,
like yeah. I'm not sure. I think it's also being done traditionally in the Philippines, this type of fishing before. But in Malaysia, supposedly it's supposed to be banned, but the orang asli or the natives still probably using it because it's been done for maybe hundreds of years. So
All right.
yeah, it's a natural compound. It's not, and the thing is that this compound from the wrist is also used as insecticide. It can repel all kinds of maybe insects when it's applied on the body.
Okay.
Yeah, so this is a very interesting case we managed, and luckily the child came about. It's just giving time. We managed conservatively, but we are not sure whether the urine alkalinization has any effect or not on this child. But you can see all the what do you call acidosis all reversed with time. Yeah, I don't think that's dialysis done as well, right?
And probably I have.
Yeah, go ahead.
Probably I might just have another question regarding the progression of the clinical scenario. At some point of time, this child, she was put on inotropes. So obviously there is some BP crisis. So I'm not sure whether there was any kind of concomitant sort of like probably anaphylactic shock, or just because of that deep acidosis.
No, it's just purely the chemical, not anaphylactic.
Yeah.
Okay.
All right, thanks.
For anaphylaxis, you need to have, like, for example, previous exposure, right? You are supposed to have like a hypersensitivity reaction, but this is the first time that they ate this plant, so very unlikely, and no other like dermal signs and symptoms as well. Okay. All right. So can if a participant has any question, either you can try and put it in the chat box and the Q&A box, and or you can just turn on your mic and ask your question. Okay. All right. So, moderator. Yeah.
I would like to add a bit more. So since this is the program for the medical student, so probably this case will highlight to you that in the ABG, you might actually find the patient to have a metabolic acidosis, right? So in metabolic acidosis, you must know how to calculate lah for the formulas and all that. The causes of metabolic acidosis, if you read in the books, it says that actually the high anion gap metabolic acidosis divided into two, the high anion gap and so normal anion gap, NAGMA and HEGMA. So for HEGMA, people always actually remember the mnemonics rather than what the mnemonic is, the CATMAT pulse or the KULT, right? So usually people will remember the CATMAT pulse mnemonics rather than what is C, what is A, kan? Okay, so probably this will make simplified version of the high anion gap. You would remember like this if you remember as KULT means that the causes of the high anion gap includes the ketone, the urea, the lactate, and also toxins, because majority of the CATMAT pulse in the mnemonics are actually toxins. Yeah, that is my additional.
Yeah. Can you see the GCS is 10 or 15? Would that kind of maybe contribute to the acidosis as well? Respiratory depression?
For the metabolic acidosis, probably if the patient actually, I'm not sure how the patient actually
initial arrive,
yeah.
On how long?
But probably my intake on that about the metabolic acidosis, probably respiratory. Because I don't think so, because if you look into the components of the ABG, this child she had PO2 of 226, and she was just on nasal prong oxygen. And at the same time, the PCO2 is 14. So technically, she shouldn't have any issue with the ventilation, as blowing air out and accepting oxygen in.
Yeah, yeah.
I do believe that based on this ABG breakdown, probably more something to do with that probably mitochondrial level rather than to be merely because of the respiratory depression.
Mm. Okay.
I think so.
Yeah. Yeah, yeah. Well, can we see the previous slide? So this is on arrival. So the BP was on slightly lowish. Saturation was on face mask. So, but then there was a kind of a breathing was acidotic type of breathing, right? Okay. One slide before. Yeah, I think that's all. Okay, I think thank you. I think that's all. Dr. Pat, anything last words for this case?
Yeah, basically um, the plant ingestion is more of something to do with airway compromise. I think the retinone has something to do with the mitochondrial level, and it adds up to the use or to the products of the um, anaerobic. So it leads to lactic acidosis. So probably
Okay.
for this airway and breathing should be prioritized.
Yeah. Okay. All right. So thank you. Shall we proceed to the next case?
Thank you for your feedback, doctors.
So we're moving on with case 2, which is a case of rhabdomyolysis due to unidentified jellyfish and venomation. So this is a case of a 9-year-old child with no past medical history, presented to the emergency department of a hospital with a complaint of generalized weakness and pain. He had been stung by an unidentified jellyfish species that he picked up at a beach in the southern region of West Malaysia 7 days prior to presentation. So prior to presentation to the ED, he was stung on the face, hands, and feet. He sustained immediate pain and numbness. However, no immediate action was taken. The jellyfish was described as having bluish tinge color, 2 palm size with several tentacles. However, no pictures of the specimen were taken. He was taken to a primary health clinic and discharged with syrup paracetamol 15 mg per kg per dose and syrup chlorpheniramine maleate 0.1 mg per kg per dose for symptomatic relief. Over the next several days, the pain became generalized, involving upper and lower limbs, aggravated by movement and not elevated by analgesia nor antihistamine. The development of weakness of upper and lower limbs, and also there is presence of tea-colored urine from day 3 of illness. Appetite was also reduced, but he was able to tolerate orally fluids. Other than that, no complaint of chest pain, abdominal pain, vomiting, or diarrhea. At the arrival at the ED, he was conscious, GCS 15/15, and afebrile. Still with complaint of generalized muscle pain, the pain score of about 4/10, worsened with movement. The initial vital signs: blood pressure 107/68 millimeter mercury, heart rate 100 beats per minute, SpO2 98%, and respiratory rate 24 breaths per minute. The examination of the CVS, respiratory, and abdominal system were all normal. The only thing is there is bilateral upper and lower limb weakness with reduced muscle power at 3/5. He has normal muscle tones and deep tendon reflexes with intact sensation. For the investigation, initial biochemical investigation showed significantly raised muscle and liver enzymes. The first urine myoglobin result on day 8 after the incident was markedly high, which is 113,000 microgram per liter. However, the renal function remained normal throughout. For the management, it was started on pain control, which with oral paracetamol 6 hourly, and on oral ibuprofen whenever the pain score is more than 3/10. He was kept on intravenous 0.9% saline maintenance for 8 days with furosemide given to achieve urine output of more than 2 ml per kg. However, following adequate rehydration and bed rest, his muscle pain and weakness improved. The urine myoglobin repeated at 7 days was reduced to 154 microgram per liter. He was discharged and was asymptomatic when reviewed at outpatient clinic after a month. So I would like to invite the panelists to give their comments on the case presentation.
Yeah, anybody like to go first? Dr. Pat, maybe?
Yes, thank you for that case. So it's very interesting that this is a jellyfish sting, and it's a like 7 days post presentation. So uh, initially or usually the jellyfish stings would present with the symptoms of pain and paresthesia immediately after or moments after you have been stung by a jellyfish. But this one took around a few days after to have some, still have the pain and still has the
Tanya,
sensation.
so moderator can ask.
Yeah. And
Okay.
yeah.
So you think it's maybe it's because of we don't know what happened in 7 days, or is it because of the effect of the venom worsening over 7 days?
Yeah, that's quite interesting because usually the jellyfish sting will present a few minutes after the pain, a few minutes after, and even the toxin, but this one presented days, 7 days in particular. So I'm not sure what happened during the time that the patient was being managed from the primary or the hospital until the 7th day. So probably the patient had some, I'm not sure, compartment syndrome or infection.
So I think the story was the patient did go to the clinic, but then discharged home, and over a few days it doesn't get better, and then went to the um, uh, to the hospital again because it's worsening condition, and I think there was some dark colored urine as well. I think maybe. Can you see this next slide? Yeah. So he was seen at a primary clinic and discharged with just analgesia and clofeniramine maleate, Piriton. So he came back after not feeling better, weakness, and appetite reduced. So could be the effect of the venom itself, right? The thing is that we don't know what is the species of jellyfish that stung the child. We do not have the picture of the sting area, so we don't know what it appears when they first arrive at the clinic. So we can't tell whether it is, but if it is a box jellyfish, we will have the skin features, right? But we don't see it in this child. The typical tram lining and leather patterning on the skin. So yeah. Okay, next slide, please. So the urine becomes decolored, means slightly dark, which is probably a sign of rhabdomyolysis as well. So do you get rhabdomyolysis for jellyfish sting?
Mm, not with our, we didn't encounter any uh, cases of rhabdomyolysis for jellyfish sting. Mm.
Okay, Dr. Hassan, Dr. Sabrina, would you like to comment on this case?
Yeah,
We see
from
the
my side, uh, I'm not that so familiar with the actual handling of jellyfish kind of poisoning or sting, but from what I have read, Yes, there is a possibility of rhabdomyolysis associated with jellyfish stings, especially if the sting itself is like very enormous one. For sure, not for someone who just has one mark with one tentacles. Sometimes you might see pictures with the almost the whole exposed areas like just mark of the tentacles. And I'm pretty much sure there might be some sort of association between the severity of probably pain, subsequent inflammation in terms of like symptoms like rhabdomyolysis. So with the extent of the initial exposure. So the more tentacle marks are there, the more probability they might get into this rhabdomyolysis. This is just as I expect from my side and based on few readings that I have made. But the other thing here is if from the get-go not much of pain, which is like usually that's the main presenting complaint for jellyfish. If you look into their initial pain score is just 4, so it's not that much high to the point that we expect someone has a significant jellyfish exposure, but somehow he has that kind of tea-colored urine, and later on proved by the laboratory that there is or there was some sort of like rhabdomyolysis. But interesting enough, he maintained a normal kidney function. So that is a bit awkward. So yeah, I'm not sure how to explain that. But that is how the clinical scenario unfolded. Probably Dr. Sabrina might have different intake on this.
So just to bear in mind, the pain score 4/10 is in the emergency department, which he presented 3 days later. So pain may have already reduced. We don't have the initial pain score. But can we see the next page, please? Yeah, so this is the blood test. You can see the CK was quite high, becoming 71,463, and subsequently with the hydration and treatment, basically just pure hydration, it start to go down after a few days. The kidney function, as you said, you can see the potassium, sodium, the creatinine, urea, not overwhelmingly abnormal, right?
Exactly.
The creatinine, yeah. And the potassium also seems to be not so high because we expect if let's say rhabdomyolysis, your potassium will be on the higher side, but doesn't show in this case. So where does the CK comes from? Then without affecting so much the potassium level. If it was rhabdomyolysis, as we know, there will be seepage of potassium into the circulation, right? From cell destruction, yeah. Yeah, it's a bit weird, yeah. Dr. Saab, maybe your insight from this case? We had a few cases before with quite significant surface area where patient present with also raised CK level. This was a case, I think, mentioned by Dr. Naim before, I think. But this is a child, yeah.
For Malaysia, I think we are still actually facing the jellyfish stings that patient that presented with cardiorespiratory arrest, severe pain or Irukandji-like syndrome, and few of the cases that we have been consulted in Penang, which is actually at the northern part of Malaysia, Peninsular Malaysia, that presented to us with Raynaud's phenomenon. But this case that been consulted is one of the rare case that we have involving the so-called rhabdomyolysis signs and symptoms. Yeah, however, when we see the renal profile, it is quite normal and it is, I mean, really atypical for the patient with rhabdomyolysis to have normal potassium level and normal kidney function level as comparison. Let's say, for example, we have a sea snake bite envenoming, whereby if the patient is having full-blown neurotoxicity and also rhabdomyolysis, myotoxicity, all the, I mean, renal profile and also the CK will be so sky high, up to 200,000 for the CK, for example.
Yeah, and the liver function as well, right? The liver enzyme also will be raised from the
However,
envenoming. Yeah.
It is interesting for us to had a look back at the history from day 1 until day 7.
Yeah.
For what we know, actually, the patient might be given some sorts of IM ATT, for example. The patient is
Yeah, but
7
doesn't go up to 71,000 for
and
IM.
that anything was done or
Yeah.
any traditional medication was given. Or and probably as Dr. Hazan said, I mean, likely to be related to the, I mean, I'm not sure whether the body surface area, I mean, the body surface area in pediatric plays a role. The more bodies, the more BSA involved, the patient will have severe signs and symptoms. If you are talking about the box jellyfish envenomation, for example, or if kanji like envenomation. But I'm not sure about this case lah. But having said that, again, with the jellyfish sting envenomation, it is really, really rarely that we can actually confirm by actually catching the jellyfish, right? For the most that we can see is based from our clinical examination of the skin. I mean, the types of the pattern on the patient's skin, and also the nematocyst sampling. That also is not actually available at immediate. Most of the time we are actually stabilizing the patient first rather than actually analyzing the patient's nematocyst by skin tapping and everything. So I think this patient is not given any urine alkalinization, right? So it's just hydration.
I'm not sure. Can you see next? That I think that is.
Yeah.
But they give furosemide.
Yeah. So
Yeah.
no backup was given, only the forced diuresis. Yeah.
Yeah, just was okay. But the thing is that we don't, as you said, we don't know what happened the first 6 days. So the patient only present to the hospital basically on the 7th day. So we don't know how long the child has been like incapacitated at home before that. So yeah, that's a bit unusual. Anyway, so the child was maintained with just hydration, right? Basically, anything else? Selain dari analgesia and also saline, furosemide. I think that's all.
And most of the time, the patients post jellyfish sting envenomation or post jellyfish stings that presented to my hospital. My hospital is in the city, so most of the time actually been treated at the local clinic at the beaches or on the way, because most of the time the patient do not live adjacent to the beaches, right? They just actually went to the beach and then had holiday, and then they got stung, and then they get treated, and then they go back home. So most of the time, the patients that I saw would likely be on day, subsequently, 24 to 48 hours onwards, up to about 1 week. Most of the cases that I saw is actually persistent pain, or actually infected wound that to do some debridements, but not this kind of case.
Yeah. So do we know which species of jellyfish that is known to cause rhabdomyolysis, so-called rhabdomyolysis. Box jellyfish, do we have documentation? I don't think so. It's mainly from the skin itself, skin necrosis. Blue bottle jellyfish, the Physalia physalis. I think there were case reports on this where allegedly it causes rhabdomyolysis or raise CK level. But we know that in this area where the child was, the incident site, there was no sighting of Physalia physalis or blue bottle jellyfish in that area. It's a Straits of Malacca. Okay. Pat, anything to add?
Yeah, I'm just curious about the elevated liver enzymes and was the oral paracetamol dosage um, indicated here, or probably,
The
or
child was pain score 4.
four,
Yeah, they
and
just gave. I'm not sure whether it's a suppository or is it orally. It's oral.
oral. And I'm thinking with the normal creatinine levels and potassium, I'm thinking of probably a metabolic disease for this child. Yeah.
Okay. Can we see the results again? Liver enzymes are all raised as well, right? You can see LDH, AST. So the liver is working hard. Yeah. Okay. All right. So it's just interesting to see this case. We hardly hear rhabdomyolysis with jellyfish in Malaysia. Whether it is truly rhabdomyolysis, still questionable, but just have to be vigilant to make sure that you also take the blood test for CK to see the results. Okay, all right. If there's no other further discussion, any question from the floor?
We have questions from the students. The first one, do we need to verify species of jellyfish for management and how to treat unidentifiable species?
Dr. Pat, maybe?
Yeah, given that in this case you don't know the species of the jellyfish, it's always evident that you would do the proper first aid and the airway breathing circulation uh, as a basis for management and supportive treatment. In cases that you know the jellyfish thing, so there's a proper way of managing it. Depends on the species, whether it will be within the region or outside the region. So um, although it's not important to know the proper species of jellyfish thing or the proper species of the jellyfish, I think management wise it would be symptomatic treatment and always the basic principles of airway breathing and circulation. Yeah.
Dr. Hassan, want to add anything else to the question just now?
I don't think I have much to add other than what
Okay.
was said by Dr.
All right.
Patrick. I think it's spot on.
Any other question?
Next question, does vinegar, urine, lemon, baking soda help with pain from jellyfish sting?
Maybe Dr. Sabrina?
Okay, actually there are studies that been conducted quite a few years ago, comparing a few of the substance and the effect to the nematocyst unfired nematocyst. So they say that the most effective is actually vinegar. So the rest like for example the urine, the milk, apa lagi? So it's not really like
Coke.
effective lah. Coca-Cola
Some
or
use Coca-Cola. Yeah.
yes. Having said that, for vinegar ni, if let's say you have, but there is a caveat. If let's say the patient is being stung by confirmed Physalia physalis, for example, so the treatment might not be vinegar, but for our region, in Malaysia, let's say is unidentified risk versus benefit. If let's say the patient being stung, I mean the first aid that being advocated is still application of the vinegar. If we want to apply the vinegar, we must know that actually when we want to pour the vinegar, it's not just about pouring, it is about the contact time with the affected stung region. If you want to pour the vinegar to be effective, it will be you have to maintain the contact time vinegar, and also the lesion, the contact time must be about 30 seconds when you pour or spray, so that it can deactivate the unfired nematocysts from firing lah. So that's about the vinegar. In fact, actually, under Malaysian Society on Toxinology, we have actually one flyer about that. And one of the clinician from Sabah Hospital also had been actively advocating the correct first aid for community in the particular region, because in terms of educating them lah. Because jellyfish sting ni it comes in seasons in some parts of Malaysia.
Yeah, but there's also now a bit controversial when using vinegar. They were saying that even though it doesn't stop the non-discharge from discharging, but apparently vinegar caused the one already discharged to release more venom. So that's a bit of controversy there, whether to still give vinegar or not. But still under debate. To me, is a still benefit and not the benefit of maybe not using vinegar or using something else. So now they say we can use lidocaine spray to actually stop the nematocysts from discharging more and also minimize pain, because vinegar is acidic. So they say that can actually cause more pain with the exposed skin or damaged skin. So I think for as long as we don't do more harm to patient, it's okay, I suppose. Yeah. So vinegar at the moment still in the contentious issue, but we still apply it. But in our guideline, I think we have already add the lidocaine spray, right? Am I right, Pat?
Yes.
In our guideline, yeah. But
Most
it's
of
more
the
expensive.
most of the question being asked is actually what percentage of vinegar. I mean, if we are not talking about the industrial, we are talking about the 4 to 6% of vinegar that usually the one that we ate, the acid that we ate, right? So cuka makan.
The one for food, yes. Any other question, or can we proceed to the next case?
Now we will proceed to the next case, Prof. So case number 3 is also a jellyfish sting, which is unidentified. So this is a case about a 32-year-old West African male presented to the emergency department of private hospital in Penang Island after he was stung by an unidentified jellyfish. According to the patient, at 6:35, while performing a religious ritual, he walked into the sea to the waist area level when he suddenly felt an electric current-like pain over both thighs, left flank, and left forearm. he did not see the offending agent. He complained of severe pain over the affected area with chest discomfort and breathlessness. So 1.5 hours after the sting, he presented to the emergency department. The BP was 136 over 104. Heart rate is 102 beats per minute, and the oxygen saturation is 100% on nasal cannula, which on 3 liter per minute. The pain score is 9 over 10. So the action taken during that time is vinegar soap was applied to the affected area, and he was given IV pethidine 50 mg, paracorpsic 40 mg, pantoprazole 40 mg, hydrocortisone 200 mg, tramadol 50 mg, IM chlorpheniramine 10 mg, and oral paracetamol 1 gram. He did not want to be admitted because of logistical reasons and was discharged against medical advice with oral etoricoxib, tramadol, and diclofenac gel. 30 hours after the sting, she complained of persistent pain over his thigh and left flank, generalized body ache, fever, mild drowsiness, numbness over the affected limbs, sore throat, and abdominal cramps. Hence presented to a teaching hospital in Kuala Lumpur. During that time, the temperature is 36.5 degrees Celsius, BP was 139 over 85, heart rate 83, oxygen saturation was 97, the respiratory rate is 18, and the pain score is 7 out of 10. The examinations of the abdomen, cardiovascular, and respiratory system were normal. So there are some investigations done during that time. The first one is ECG. The ECG show a Wolff-Parkinson-White pattern with a short PR interval and delta waves, secondary ST segment changes, and left ventricular hypertrophy. A cardiac ultrasound was done as well with a good cardiac contractility with no regional wall hypokinesia and a thickened left ventricular wall. Creatine kinase level was taken and it shows a raised CK level with a reading of 647 unit per liter, and the troponin I level was normal. Chest X-ray was done and it was normal as well. So this is the ECG of the patient. We show a Wolff-Parkinson-White pattern. So that time the action taken was he was given IV tramadol 50 mg and saline hydration. The remote envenomation consultancy service was consulted and he was referred to the cardiology team. Once again, he did not want to be admitted and discharged himself against advice with an outpatient cardiology clinic appointment. Soon after that, 52 hours after the sting, he returned to the emergency department with persistent pain over the affected site. No chest pain or breathlessness. The vital sign and physical examination was unremarkable. ECG done during that time still showing persistent Wolff-Parkinson-White changes. The troponin I level is still normal. However, the CK level increased to 1,216 units per liter. He was then admitted for observation and pain management, and his condition gradually improved. Progression in the ward, the CK level on the following days dropped to 763, and the ECG remained unchanged. Then he was discharged after 2 days of admission with a final CK level of 392 units per liter with an outpatient echocardiography and cardiological clinic appointment. A review of patient progress 30 days after the injury did not reveal any persistent sign of envenomation or chest pain. The wound from the sting had healed with minimal scarring, and the repeated ECG showed no changes. So this is the investigations done during the admissions. And this is the picture of the sting. That's all for the case. Now I would like to invite the panelists to share about their thoughts about this case.
Dr. Hassan, would you like to go first, or Dr. Pat?
All right. Okay, I think this case more or less brought in some issues from the previous case, but the add-on layer here is that his presenting complaint all the time is pain. So for those kind of cases, clearly from the skin marks that there is jellyfish stings kind of marks, and obviously it seems to be extensive thighs, and I can see the hands also there. So though this gentleman, he kind of AMA for some reason, and I can see that he was discharged with the cocktail of analgesia, including diclofenac and tramadol and all this. So I'm not sure in these kind of cases, since we think this is a jellyfish and obviously extensive, and the probability of AKI, which might relate it to later on, probably with CK and the potential for the kidney issues. So probably we might be more selective when it comes to our painkillers. So we try to move away from the NSAIDs and all this, just as a precaution. That is fine. The thing is, I'm not sure whether I have seen the urine for myoglobin on the blood. Can I see the blood results, please? I didn't remember that I have seen the urine myoglobin.
No, I don't think there's urine myoglobin. It's mainly the CK or CRP.
Yes, I think for those kind
CK,
of cases,
not so
yeah,
much
for
raised,
those,
right?
yeah, because for the subsequent visit, the CK raised up to 1,000. So yes, CK might not be synonymous to the myoglobin, but I do believe that for those kind of cases with that kind of creatinine, probably will be much sound if we have done the myoglobin just to see whether or not we are truly dealing with the some sort of myoglobin rather than just CK. That might have some impacts on the management probably, and probably that if like clearly informed to the patient, probably he might change his mind about the AMA discharge. I think that's my intake on this.
Okay, the or
Yeah.
the sub.
Yeah. I was just thinking if there was first aid treatment done on the unseen and in the hospital, first hospital. Um,
The private hospital, right?
yeah. Okay. The serve vinegar and okay. Affected area. Well, with the guidelines given in the the current guidelines that we are adapting, aside from vinegar, if it is in a hospital setting, we can place hot uh, water immersion or cold water immersion depending on the species. And I think that would um, gradually eliminate some of the pain that the patient might be experiencing, as well as decrease um, the nematocysts that would be um, um, eliciting some of the toxins. And I'm not sure if um, hydrocortisone would be appropriate for this case because it's not an allergic reaction, and pretty much that there are a lot of medications that were given for such case. He had the tramadol, we had paracetamol, we had betadine and parecoxib. So it's very overwhelming to have those um, medications given to this patient. Yeah. Okay. I think granting that the pain score is 9/10, but of course with the decision of the patient that he needs to go on or go home without further advice of the medical personnel, he returned immediately after and had this Parkinson White syndrome. So I think uh, I'm not sure. It was mentioned at the end that the ECG was normal after. Was it right? yeah, minimal scarring, and the ECG was normal. So I'm not sure if there will be uh,
No changes meaning normal, or
no,
is it the
same,
same?
same. I was shown no changes. No changes, or is this the
Yeah,
same as
could
capability?
be a normal variant, could be a
Normal.
variant, it's a
Okay.
African, so West African variant, could be a normal thing, but he has no cardiac follow-up. I think he was asked for a cardiac follow-up, but we're not sure whether he went for it or not. Yeah, but the cardiac enzyme was with the normal,
Steady.
right? So
Normal a bit. Yeah.
so there was unlikely to be related to the jellyfish sting, even though we have some changes in the ECG. Anyway, yeah. Okay. So what about the skin changes? Do you see the skin marking? What do you think, Pat or Sabrina? Do you think it's from a box jellyfish or something else?
Something else.
Something else.
Something else. It's not a typical. Maybe a carb.
Yeah.
It's not. Well, it doesn't mark like a box jellyfish.
Really? Mm.
Mm, let me
It's
see.
on the arm as well, right? Yeah. Yeah. Was there hypertension? No.
No.
Okay. In the few cases that we saw, it can actually cause hypertension, right? For example, the four-tentacle jellyfish. Anyway, this doesn't look like a four-tentacle jellyfish sting. Okay, all right. So, Sabrina, you want to give your thoughts about this case?
Just curious, we are repeating the CK. I mean, this case is actually presented after the consultation of the second case, is it?
Yeah.
Now the because it is actually reflected in the serial CK monitoring and everything. Having said that, the patient is being given IM before. But of
So that's
course,
why
it
the
is
CK
not
was not that high. CK
Mm.
was 763,
Um,
most likely from the IM injection. But the first case just now was 72,000, right? So it's markedly
yeah.
different. That was not due to just IM injection. Yeah.
So it is obvious that after the 600, it came up to 1,002, and then actually it come down. So basically, if it is already peak, usually it will come down and down. The,
Yeah.
we cannot actually exclude whether this is not box jellyfish. However, I think in the case of unidentified jellyfish sting, the treatment is still symptomatic. I'm not sure whether the patient is being given any magnesium sulfate or not.
No, I don't think so.
I don't think
Moderators, ada ke mention magnesium sulfate? I don't think so.
ada.
Just analgesia, tramadol. Okay, anyway. These are just weird case that we've been getting for our consults. It's thought quite interesting to discuss. Not straightforward, right? We require some observation and thinking out of the box as well. And we are thrown in with the ECG changes. So should we react, panic or not with that? So yeah. Okay. So any other questions from the participants, moderators?
Yes, there's one question. So the question is about when is the antidote or the antivenom for jellyfish is indicated?
Maybe Dr. Sab or Dr. Pat?
A few indication of the antivenom, particularly box jellyfish antivenom. If we suspect the patient being stung by the box jellyfish based on the sign and symptoms adalah number one, if let's say the patient is in cardiorespiratory arrest and the hospital is just right away, while doing the CPR. Nombor satu. Nombor dua, if let's say the patient is having cardiorespiratory manifestation and is unstable, so there's a second indication. Number three adalah if the patient presented with cardiac and also respiratory but is stable but manifests as APO, for example, so it's an indication. Number four adalah if in severe pain, despite of all analgesic that we have given, still refractory and still have severe pain, so there's an indication. So there are multiple suggested vials for it. So but anyway, not all hospital in Malaysia have the box jellyfish antivenom. Nowadays, the antivenom box jellyfish antivenom is available in Sabah in 3 hospital in Sabah. Hopefully, in the future, we will have the antivenom being stored in a few of the island in Malaysia that have got a lot of actually cases of jellyfish sting, so that if the patient need it, then we can give. Yeah, that is my info.
Philippines
Although
is with antivenom or not? I don't think Philippines tak ada,
No.
not yet.
Not yet.
Okay.
but if let's say we do not have antivenom, I think the symptomatic treatment and good supportive care is of utmost important lah.
That's it.
Alright.
Okay.
Thank you.
Next case.
Okay.
Is there any other question?
So now we're moving on to case number 4, which is case of Naja species bite injury. A 32-year-old construction worker was bitten on the dorsal aspect of his left foot by Naja species snake in the late afternoon. So 1 hour after the incident, he was brought to the emergency department and presented with drowsiness and profuse sweating. His vital signs were heart rate was 65 beats per minute, blood pressure 105/79 millimeter mercury, respiratory rate 18 breaths per minute, and SpO2 97% on air. During that time, the action taken was to give IM adrenaline 0.5 mg twice, IM anti-tetanus toxoid 0.5 ml, IV morphine 2 mg, and IV fentanyl 50 microgram. So on examination, it showed a broken off fang still embedded on the skin with a few punctured wounds, as can be seen in picture A, and surrounding skin discoloration around 1 hour post snake bite, as can be seen in picture B. This systemic examination was unremarkable. Initial investigation did not reveal any significant abnormality. 6-hourly serial blood tests were performed. For the antivenom administration, the Remote Envenomation Consultancy Services (RECS) was consulted for patient management. An initial dose of 10 vials of Naja Kotia antivenom from Queen Savaba Memorial Institute, Thailand was indicated, and the antivenom was administered as per Malaysia Ministry of Health guideline on the management of snake bite. However, the patient developed chills 30 minutes after completion of the antivenom with a recorded temperature of 37.6 degrees Celsius. But thankfully, he responded to antipyretics and no further reactions occurred. As for the case progress, the patient was later admitted for continuation of care. He was monitored for the rate of proximal progression, pain score progression, lymph node and progression of local tissue injury such as dermonecrosis and blisters. 12 hours post snake bite, he developed a temperature spike and the expansion of dermonecrosis. Also, there is progression of the swelling proximally. The distal circulation of the limb remains intact with CRP less than 2 seconds. Later, he was started on IV amoxicillin clavulanic acid 1.2 gram 8 hourly and subsequently changed to IV ampicillin sulbactam on day 2 due to persistent temperature spike. As you can see in picture C, this is the progression of dermonecrosis at 6 hours, while picture D is the progression at 12 hours. The swelling and redness of the limb progressed up to mid-shin level, and the necrosis expanded distally over the dorsum of the foot. His pain was well controlled with regular IV tramadol, 50 mg 8 hourly. So picture E shows the worsening swelling and redness on day 2 with presence of skip lesion, and also picture F is the comparison with the normal limb. Next, at day 5 post snake bite, the orthopedic team performed wound debridement. Intraoperatively, there is a liquefactive necrosis of subcutaneous tissue over the anteromedial aspect of the left ankle, extending to dorsum of his forefoot. And necrotic tissue was debrided and 50 cc of pus drain. So picture G shows the wound condition on day 5 prior to the wound debridement. Post-operatively, he was transferred back to the orthopedic ward. Culture of the wound revealed a growth of Morganella morganii sensitive to cefepime, and therefore the antibiotic therapy was changed accordingly. He had 3 cycles of vacuum dressing with repeated tissue culture. Later at day 27 post-snake bite, following a normal floral skin growth or repeated culture, he had split thickness skin grafting done. So you can see the picture H show that the wound before the split skin grafting, while picture I showed how the wound looked like after the skin grafting. Later, he was discharged well, 5 days post skin grafting, with daily wound dressing of recipient site at a nearby health clinic and weekly wound inspection at orthopedic clinic. So, picture G show that the site of skin grafting 6 weeks after, and for picture K is the donor site at day 5, and picture L is the donor site 6 weeks after. So that's it for the case. I would like to invite the panelists to give comments on the case presentation.
Okay, anybody would like to start first? Hassan?
Thank you for the case. Obviously, this young gentleman, clinical scenario-wise, history-wise, is like very conformative for bite, snake bite. Probably initially we might not know exactly what is the type of the species of that snake per se, but as I have said, history and clinical finding pretty much suggesting so. So in this kind of scenario, the establishing of envenomation is quite crucial. So of course you start with the ABCD, stabilization and all the symptomatic things, but the most crucial thing here is to establish whether or not there is an envenomation, because that will guide whether or not you will give your antivenom, because the antivenoms, the earlier you give, the better you might be the results. So I'm pretty much this gentleman. He was the establishment of the envenomation was early on, and Rex was consulted, and the antivenom was given. But surprisingly, when I look into the initial might be adjunct medication, there is some sort of trend, like kind of indicating that there might be some sort of allergies, because I can see hydrocortisone there. And can I go back into the initial medication that which was given, or
This one.
all right, sorry.
Yeah.
No,
So this
no,
was
sorry,
given before
the adrenaline.
yeah, this was before consultation to Rex.
Yes, correct. But I'm just a bit curious, why that adrenaline? Was there
Yes,
anything
exactly.
that
We were asking the same question.
yeah.
So
Yeah.
it's a misdiagnosis actually. They assume all these findings were drowsiness and profuse sweating and so on was due to an allergic reaction, which is not. It's actually an envenomation. So anyway, yeah. So the next page. then they were consulted to Rex, and we can see that antivenom was given after consultation. Yeah.
Yeah, and to my surprise, is they mentioned that there is a fang is still hanging there.
Yeah,
So,
yeah.
uh,
Can go
is that
back one
something
slide.
common?
Yeah, you can see the fang sticking out at the puncture wound where the blood.
Interesting.
So
Is
that's
that
a foreign
something that common
body.
you would see?
No. So that's why
Okay.
this is interesting picture. It's not very unusual. Usually we will find the fang inside under the tissue, right, as a foreign body, but this
Mm.
is still sticking on the skin when the patient arrive. So
Oh,
it's nice
interesting.
that they took a picture, and I still have the fang with me.
Wow, interesting.
Yeah. So that's a early sign. As you can see, the picture B, you can see the more necrosis already forming, right?
Yep.
Yeah. Okay.
And sorry, Dr. Cardona, I just want to ask here, since from time to time we might see those kind of fangs, it might be sticking out or it might be embedded down there, would it that kind of indicate we should have go for X-ray for whoever is bitten by a snake,
Uh,
or
yeah. Yeah, that's a good question. Well, obviously for this one, we can see the fang, so we don't need to do X-ray. But for most of the time, let's say we have a non-venomous snake bite, which is typically from a python bite. Python, the teeth might break off easily and embedded under the skin. So for those type of injury where you have some laceration and so on, you can do you can do one X-ray, to look whether there are foreign bodies still sticking. And some cases that we have seen, we could see the fang in the X-ray. Obviously, if we saw that, then we will have to refer for exploration and removal of the foreign body, right? Yeah. So yeah. So yeah, good question. Do consider doing a X-ray. Uh, Sometimes, from one case that we had before, is a cobra bite, and this one is sticking on the skin. But the one that we had before, it went into the joint. The bite was over a joint, and the fang broke off and lodged into the joint. So definitely we require exploratory surgical intervention by the orthopedics. So apparently in that case, because of the involving the joint, it causes arthritis, and it was a child. Um, and what happened was K wire was inserted and so on. So the child grew with the middle finger shorter than the rest of the fingers as she grew. So cosmetically, not pretty, but she was alive. Yeah, yeah. That's an interesting experience.
yeah, thank you.
Yeah. So just be caution. It could be left with a foreign body. We had also cases where someone was bitten on the scrotum, and foreign body was left in the scrotum as well, and also the hand, uh, which was not identified at that time. But the patient came back a few days later saying that something was sticking out from the wound, and we peel off the few teeth of the snakes from the wound a few days later. But the patient was okay, no secondary infection. The patient was given antibiotics as a prophylaxis at the time, because the wound was quite extensive. Yeah. Okay. So yeah. Any other questions or anything discussion, comment, Pat, about this case?
Yeah, just want to comment regarding the use of, um, I mean that the management for the giving of the antivenom. So it was mentioned that immediately after the 10 vials. The 10 vials were administered to the patient. The patient developed chills. So whenever you have those incidents, you might opt not to stop the giving of the antivenom, but give adrenaline just to um, prevent the anaphylaxis for this patient. Yeah. And regarding, there are some institutes or units in the Philippines that uses hyperbaric medicine in the management of the wound. So in the southern part of the Philippines, where hyperbaric machines are available, there were studies that revealed that they have more um, um, improvement for the wound uh, um,
Wound
recuperation
healing.
and wound healing. I mean, in lesser days for wound healing, with the giving of or the use of the hyperbaric oxygenation. Yeah, just to mention to that.
Is that only for those with poor nutritional value, or let's say somebody with diabetes, or is it
Yeah,
for all
yeah.
patients?
All patients. We use that
Oh,
for burns, for diabetic,
burns, yeah.
and currently snake bites with, I mean, those with dermatonecrosis and those
Mm.
with non-healing wound for quite a long time.
Do you perform skin grafting for patients
We
like this?
we hardly do skin grafting with those patients.
Okay. So patient healing with a big scar then, yeah? Or
Yes.
how does it work?
Uh,
Mm.
with the wound management in the Philippines, we use the traditional method of um, debriding uh,
Mhm.
the dead skin
Mm.
until there will be uh, development of the new skin. So it usually takes some time before the wound heals and have a new layer of skin.
So maybe that's why you say the hyperbaric may be helpful in that sense.
Yes,
Yeah,
yes.
okay, right. Okay, Sab, you want to comment about this case?
Okay, I think this is a good example of the Naja species bite and reanimation, local and systemic, because when the medical students saw or actually go through the case studies just now, so you have seen the typical necrosis. So when you are becoming a doctor one day, you know that if the patient presented with snake bite and there are the necrosis like this, so this is not like ecchymosis or actually bruising in a patient with snake bite. So this is the example of the necrosis. Once you look at it one time, so hopefully you can remember until you becoming houseman and managing the patient, right? Okay, because most of the time in our hospital, for example, they haven't seen the more necrosis part. So when we have got a case, although the patient is having manifestation of the systemic, they also presented with apa ni, local envenomation, right? So they cannot identify that. That is number one. Number two, if you see the progression of the um local lesion, you can see the skip lesion. Dia akan jadi macam peta. So that is the typical skip lesion that we can see. Number three, yeah, I think there are a lot of learning point that we can learn from this case, including not to manage a snake bite as per anaphylaxis when the patient comes to us. And just be remember, if let's say the patient is having shortness of breath and you give the oxygen, the treatment is, if the patient is presenting with respiratory paralysis, for example, and the patient decide, okay, so do not actually satisfy by giving the oxygen. For example, oxygen is dropping, so give the oxygen and then you satisfy because the oxygen is already more than 95%. I mean, for what we know, yes, the patient would probably need oxygen, but at the same time, also the patient might manifest as a neurotoxicity that you need to give the antivenom on top of it. So because we learn from a few of the mistakes that been done in the past and everything. So that is the number what already? So learning point lah when managing the Naja species bite ni from our center, right? And then split skin grafting is what being done by our colleagues in the plastic or in the plastic combined with auto actually going in with a wound department. Less ataupun rarely now that we perform so-called parsotomy, because we know the pathophysiology of the snake bite is more of the envenomation syndrome, unless it is actually very very typical. The patient kita dah optimizekan the treatment and the patient still has a um, um, uh, swelling. So rarely that we perform fasciotomy nowadays. We actually rather than we actually will optimize the patient with antivenom therapy first lah. Of course, we will get the orthopedic on board for the management of the wound later on. Dr. Patrick's suggestion tu macam it is quite macam good in terms of future researchers lah in this kind of local envenomation, I think.
Yeah, we have the issue is that we can't do real double-blind control trial for that. Nobody want to volunteer to be bitten by a cobra skin, unless you can use it for example, mice or mouse, inject for induce dermonecrosis and see how 50% without and 50% with oxygen therapy. Yeah, okay. All right, so any questions from the floor?
We have one question. What can a bystander do when encounter someone bitten by venomous snake? And like we saw in movies, will tourniquet stop flow of venom, and can we suck out snake bite by mouth?
Okay. Dr. Hassan, want to try?
Thank you. I think this is it will come under the pre-hospital kind of care. And for this kind of scenario, yeah, everyone can be bitten anywhere and everywhere. But the most important thing is we have to have some sort of standardized approach. So if someone get bitten, the first thing is try to assure him or her, reassure her. Try to kind of put him in any kind of stable position. So shouldn't allow to walk around or like keep kicking around. So just reassure the patient. Try to immobilize first by just lying in a comfortable position. And if you have any sort of facility, you might just immobilize the affected side. When I say immobilize, by no means I mean like kind of tourniquet binding and all this. I know that everyone is like, the first, okay, you bitten, you just, they keep tightening whatever is bitten there. So I'm saying immobilization. So immobilize, for example, if someone was bitten on the foot, just stabilize the whole leg. And the second thing is try to scoop and run to the nearest appropriate healthcare facility. And to me, if I have my ambulance crew and there was a hospital maybe 10 minutes drive, but they don't have the facility for antivenoms and all this. And there is another hospital like probably half an hour away, but have all the facilities. I think the idea is just run to where there is a facility to handle these kind of cases. So my point here is the pre-hospital management pretty much simple, but sometimes it might be a bit hectic because the emotions are high and everyone is like just unsure. So try to assure everyone over there. keep him calm, try to immobilize if possible, and send him as soon as possible to the nearest clinic. Not so much advice to play around like doing tourniquet or like kind of sucking the wound area by your mouth as we used to see in the movies and all this. So that is my intake on this. Thank you.
Okay. Pat, last comment on the question. Anything? In Malaysia, tourniquet is the most common thing we see for snake bite. Yeah, almost all cases. I don't know what's wrong with the public. They keep on tying the beaten limb to come to the hospital. Yeah.
Yes,
Because
similar
emotionally
to the
satisfying.
Philippines.
Yeah.
Yeah, it's similar to the Philippines. We have a lot of cases with tourniquet, and of course, herbal medications that are being applied to the wound. No, so they
Yeah.
typically massage the area and
Yeah.
give place the oil and the leaf
Mm.
in the on top of the wound. So the first one I just want to share. There was one um, Facebook group who just mentioned that why wouldn't you not place tourniquet? Why would you place tourniquet for this snake bite cases? So there were issues on uh, that's the best way to prevent the spread of the wound because you're impeding the flow of the blood, and some would tell that uh, what if you don't have the antivenom, it would this the tourniquet would prolong the spread of the wound of the venom to the rest of the body. And then I just mentioned to them, what if the snake species that bit the patient is not venomous, or it's no there's no envenomation. So most probably that the patient would suffer because first the patient would have swelling that would be a symptom or a sign of envenomation. Second, if there is prolonged transport, the patient's limb might die and would have to have an amputation when the patient arrive at the hospital. So basically, the there are still groups who would want to advocate the tourniquet, but of course, with the advocate education and the proper uh, um, talking to
Yeah.
them on the physiology of
Yeah.
how we explain to them why would you not place a tourniquet would be appropriate.
Yeah. Okay. Right. Thank you. So I think we can close the session. We have Kahoot quiz. Am I right? Do you have any other question?
Dr. Khaldun, can I just have a quick question?
Yeah. Sure.
Dr. Khaldun, by the way, what I have noted here is whenever there is a snake bite, there is an antibiotic. So I'm not sure whether that's something by default or something has to be individualized.
Uh, it's supposed to be by indication, right? So for this case, the indication is the very big tissue destruction. So that was given as early. The antibiotic was given early, initial as a prophylaxis, not prophylaxis for treatment. And then once we get the culture and sensitivity, we change the antibiotic according to the Mogadera sensitive antibiotics for this case. So we don't give antibiotics as like every snake bite we just give. No, there's an indication even in the Malaysian guideline for snake bite from the Ministry of Health. Patient with immunocompromise, for example, with diabetes, patient with significant skin tissue destruction, those can be given as prophylaxis. But otherwise, antibiotics is given as treatment, not as prophylaxis per se. Yeah. So not everybody should get antibiotics unnecessarily. Yeah. Okay. Any other question? Otherwise, we proceed with the next program.
So that is the special prize for our winner. So for the Kahoot session, we like to give the floor to Prof. Holden.
Okay. Yay. Number 3, A178498. Number 2, 1010. And the first. Wow. Okay. Congratulations to the winner.
For our closing remarks, please join me in welcoming back Dr. Ruth Sabrina. Without further ado, Doctor, the mic is yours.
Okay, so I hope that you enjoy the I think more than 2 hour session apa ni in the recent session hari ni. So obviously like for me, I also involved in teaching medical students here in Perak, namely the Royal College of Medicine Perak. So what we do in the teaching is that in the emergency department unit, I allocated around 1 hour to discuss about clinical toxicology. What you guys have for now is actually is a great session. So hopefully you can actually attend it throughout the year. So that it can actually increase your knowledge in clinical toxicology, so that you, when you are joining the housemanship and etc., you have a bit of knowledge of how to manage appropriately from the primary care until a referral and when the patient being admitted until discharge. So congratulations to all of you. All the best. Thank you.
Thank you, Doctor. And once again, thank you so much, Dr. Ruth Sabrina, Dr. Hassan Adam, and Dr. Patrick Tiklau, and Associate Prof. Dr. Cowden. It was an eye-opener to hear from the views of experts. We will display the QR code and link for the e-cert, so stay tuned.
Congratulations and well done everyone for your effort. We hope with this seminar, Q&A session and quiz, the medical students in attendance managed to grasp some concept pertaining to clinical toxicology. It might be the first step to a long journey. Who knows, some of us may end up aspiring to fill the shoes of some of our panelists here. I hope everyone here benefited from this session in widening perspective and gaining knowledge. It was a pleasure to have all of you with us today.